Everybody. Thank you so much for joining us this webinar. We will start in a couple of minutes' time. We thank my friend, our guest speaker, for honoring the invitation. And thank you so much once again to this webinar on breast cancer diagnosis and management during the COVID-19 pandemic. And thank you once again for joining us for this meeting. We're especially grateful for the kind reception from Mr. Emmanuel Garefa, my good friend, who is originally from Italy, but now practices in London, in UK, sorry, I beg your pardon. He is a consultant breast and plastic surgeon of the breast unit at the University Hospital of Derby and Burton in the UK. So he'll be taking the discussion, but I just want to give a brief introduction on why we are here. So we know that the current reality of breast cancer in Nigeria and Africa as a whole is that we tend to see patients with far advanced disease and typically stage 3 and stage 4. And there are a lot of issues surrounding that in terms of poverty and socioeconomic disdain and the like. Unfortunately, with the COVID-19 pandemic, we are seeing peculiar challenges. We have at least 4 different categories of patients who are related to COVID-19 infection that we encounter in this kind of scenario. There are patients who are symptomatic of COVID-19 infection, who have breast cancer and we have to treat. There are some patients who will be infected but asymptomatic. We still have to treat those patients. There are some patients who have had COVID-19 infection and then recovered from the disease and then come with breast cancer. We have to consider the treatment for those patients. And finally, there are those patients who have breast cancer and have been exposed to individuals with coronavirus and they have potential risk of infection. So those 4 clusters of patients are the things that we tend to encounter in our environment. And unfortunately, the issue of the pandemic and the delays that have occurred in breast cancer treatment have caused a number of peculiar situations. We are seeing more and more patients with advanced disease because patients did not come to the hospital for care. We are seeing patients who are going to non-qualified practitioners, getting their surgeries done and coming down with surgical complications. And then finally, we are seeing patients taking non-operative treatment longer than necessary because they didn't want to come to the hospital and having side effects from those. And so these are issues that we have to address as we go on the discussion. So without further ado, I would like to invite my friend Emmanuel for his presentation. I will stop sharing my screen and allow him to share his slide. At the end of the presentation, we will take questions and comments. As the presentation goes on, please you can send your comments and your questions into the chat box. Thank you very much.
Hi everyone, thanks for joining and thanks to Ademola for inviting me to have this talk.
So maybe you can share your screen.
Let's see. That should work, hopefully. Okay, can you see the slides?
Yes, we can see your slides.
So, as Ademola said, my name is Emanuele and I trained in Italy, but now I'm working in the UK as an oncoplastic breast surgeon in Derby. And today I will talk to you about the diagnosis and management of breast cancer during this coronavirus pandemic. What I will do mainly is talking to you about what's been our experience here in the UK. Of course, the situation is completely different from what you have in Africa. The age and type of patient that you see is completely different. How the hospital setup is different as well. But I think some principles apply worldwide, and hopefully you will find this interesting. I've also had some real-life example from my practice, which I will share with you, and hopefully we can have a little discussion about those. So I haven't got any disclosure. And from my point of view, my idea of a pandemic like this one, which has hit every country really hard, it's I compare it to a tsunami, like a huge wave which comes from far away and then it's a country. So I think during this pandemic, we've seen 4 phases. The wait. So when you know that something is coming, you can try and brace, get ready to it. Then the acute phase, when the actual wave hits you. Recovery, when sort of the wave is passing by and maybe you're surfing on top of it. And finally, the aftermath, when you've dealt with the damage and you need to recover from it. So the weight, this is a picture from the tsunami that hit Indonesia in the past. I don't know if you have ever read about it, but before the actual wave comes, the water will retract, like here. So like the water will go back into the sea, and you will be left with a view like this. So people who maybe know what's going to happen, they will try to run away, get on top of a building, and kneel. People who don't know, they will just stay there and watch until they get it. So this is the wait, from my opinion. It's an important phase because it's when you've got the chance to get ready and see what's going to happen. Not all the countries had the chance to prepare. For example, China, they were hit first, so they didn't have the chance to prepare. Italy as well was quite unexpected. Here in the UK and elsewhere, there's been more time to prepare. And during this phase, you will still continue to operate and see patients as normal. But what you need to do is mainly create contingency plans for when the pandemic will hit you hard. So you have to think about what if our colleagues are sick? What if they shut down theaters? What if they redeploy us to do emergency work and we have to stop doing cancers? So you will start cutting on all services that are non-essential, non-cancer service, like breast reconstruction. And you will prioritize your cancer work. Clinic, pretty much in this phase, they run as normal, but you may want to prepare like stocking PPE, see if you've got tools for virtual consultation, if you can get some softwares to do that. You will stop all non-essential service, and you may start thinking about doing virtual clinics or maybe phone call in the high-risk patient groups when no clinical examination is required. For example, patients who are treated with anti-estrogen tablets as primary treatment, or family history clinics. Surgery is still going on. What you may want to do is cancel or non-cancer work, because if your theater lists are going to be reduced or maybe completely shut down, you may want to crack on and do as many cancer as you can, as soon as you can, and avoid having a waiting list if you can. This can also influence the decision making when you think about surgery. For example, if you perform lumpectomy and then you've got an involved margins, you need to make the patient aware that you may not be able to go back to bring her back to theater for another operation. And I think the key is forward thinking, planning ahead for multiple chances and be able to adjust. That goes for the service organization and also for when you're treating a patient. You have to have plan B and C ready. An example from that phase, this is a patient that was diagnosed with screening with high-grade DCIS. There was an area of 35 millimeter of calcification in her right breast. Her choice was to have breast-conserving surgery, and because it was quite a large area, when we initially discussed surgery, I discussed with her to do partial breast reconstruction with a chest wall flap in 2 stages. So I planned to do a lumpectomy first to see if the margins were clear, and then 3-4 weeks later, after the pathology report, go back and do the reconstruction part. So the first surgery was planned mid-March and the second one mid-April. As the day for the first surgery approached, we started to see a rise in COVID admission, and it was in the air like the theaters were likely to be shut down anytime soon. So in this situation, I had to think about what to tell the patient on the day, what should we do. So that's here. Think about it, and we'll go back later to discuss it. And then the acute phase, when the pandemic actually really hits you hard. That's when you've got a substantial reduction of all activities, including cancer work. You may experience limited resources. Some colleagues may be off sick. Some may have to self-isolate at home, not be able to go to work. Some staff may be deployed to intensive care or just to do emergency work. And in this phase, it's very important to be flexible. In terms of diagnosis, as you know, in the UK, there is a screening program with mammogram every 3 years. This provides us with a good half of our cancer work. That is stopped, of course. You will also experience a reduction in referrals from the GP. Many patients will also be scared to come to the hospital, particularly elderly, and they may also be scared to refer to the GP for their symptoms. What you have to do is try and reduce as much as you can the amount of people coming to the unit. So we will have an increased use of telephone consultation, even for symptomatic patients and follow-ups. And also it's very important that you keep the number of staff actually working together at the same time as low as possible. Because if one of them gets infected, then you may have to stop your work completely. So it's very important that patients physically attend to the hospital only when there is a very high suspicion of cancer, providing that there is enough staff to run the clinic. All the patients, before coming to the hospital, should be called by the reception service to see if they have symptoms. And of course, if they have symptoms, they should be told not to come and the appointment should be rescheduled. For all referrals with a lower index of suspicion, a telephone consultation can be arranged. And if, for example, a GP refer you a very old patient, maybe in a nursing home with a suspicious cancer, those should not be seen until the situation has changed. And what you can consider to do is tell the GP to start them on primary endocrine treatment with an aromatase inhibitor, as the majority of cancer in elderly patients are estrogen receptor positive anyway. Talking about triaging this referral, my view is that an initial telephone consultation is appropriate in the majority of cases anyway, because that will allow you to get a good patient history and a catch on their comorbidities, so you can also discuss the risk and benefits of coming and potentially getting COVID or delaying their diagnosis. Also, you can consider women who are pregnant, or if they have little children or very elderly people at home, they may get the virus and pass it to them. So you want to discuss it before you actually see them. Generally speaking, breast pain, bilateral nipple discharge, particularly if in young women less than 30, they can be discharged after telephone consultation. And imaging like mammogram can be arranged at a convenient time if necessary. Women with benign looking lump, or maybe young women with lumps and no family history, you can arrange a follow-up telephone consultation in about 4 weeks. Most of the women, they will have just noticed that lump and call the GP. Perhaps waiting after one period could be an idea, because many of the lumps will disappear anyway. All those patients, what is really important to do is to make solid arrangements to keep track of all of them. You don't want them to get lost. All these patients should be offered an appointment and be physically reviewed at some point when the pandemic allows so. What if a cancer is then diagnosed? The first thing you should do compared to what you would normally do is place a marker clip in every malignant or suspicious lesion that you biopsy. This is why, for example, if you don't have enough theater space to operate on ER-positive cancers, then you may want to start them on primary endocrine. And the clip has to be there to mark the lesion if should that disappear for when you can operate them. Also, if multiple lesions are seen in the breast, you may want to biopsy all of them at the same time to avoid further attendance for further biopsy. And of course, every patient should be discussed on MDT, and additional imaging should be discussed on a case-by-case basis. For example, staging CT scans. If it's not possible, you can omit that. We normally offer an MRI scan to every patient we find with lobular cancer. Maybe during this pandemic, if there is a clear mammogram with a solitary lesion, you could decide to omit that. As I was saying, there may not be enough theater space to operate everyone. So you have to prioritize surgical treatment based on the severity of cancer phenotype, but also taking into account patient comorbidities and age. So the Association of Breast Surgery provided some guidelines about patients who should be prioritized for surgery. Definitely estrogen receptor negative patients should be on the top of the list, followed by HER2 positive patients. Premenopausal patients, particularly if grade 3 or not positive, also they have priority. Larger areas of a grade DCIS. Postmenopausal women with estrogen receptor positive cancer, these are low priority because you can start them on primary endocrine and wait for surgery. And again, the remaining DCIS patients, they can wait without problems. Neoadjuvant chemotherapy, we use it a lot in the United Kingdom to downstage cancers to allow breast conserving surgery. During the pandemic, you may not want to do that because chemotherapy will involve multiple attendants to the hospital, and the patient's immune system will also be compromised. Also, if you wait during chemotherapy and the situation gets worse, you may not be able to operate the patient when they need. So surgery is the main treatment, and neoadjuvant chemotherapy should be limited only to inoperable cases. And patients currently on neoadjuvant, you may actually want to operate on them sooner than planned. And as I said, when theater capacity is reduced, you can start putting estrogen receptor positive patients on primary endocrine. And then if there is not enough space, also premenopausal patients, you can start them on primary endocrine, even if there is not solid evidence in that group. Also, something that you can discuss and consider is performing an oncotype test on the core biopsy for young patient with grade 3 not positive cancer. And if these patients, they have a low recurrence score, then you can safely assume that they will not need chemotherapy, and you can start them on endocrine treatment before surgery. If they have an high score, then you will want them to prioritize them for surgery. All those patients that you're not operating on, you will have to keep a waiting list, and this will have to be priority based according to the criteria that I've mentioned you, and also take into account the comorbidities, because of course, a patient with comorbidities will have to wait, or at least you will have to discuss it. In terms of surgery, the goal would be to do as many patients as possible as a day case. All complex oncoplastic procedures should be avoided because of time constraints in theater. Immediate breast reconstruction should not be offered, as well as non-cancer surgery like contralateral symmetrization. If you perform sentinel node biopsy, that shouldn't involve technetium because that would require an attendance to nuclear medicine. So you want to minimize patient wandering around to the hospital. So you should limit the use the sentinel node to blue dye or Indocyanine green that you can inject in theater. Surgery for breast cancer should be always performed in protected non-COVID acute sites. All the patients should be tested before being admitted to the hospital and should also self-isolate. All surgeons should be able to use full PPE when operating. Some cities in the UK have trialed with success the use of cancer hubs. So, for example, in London, all the cancer cases converged to one hospital, the Royal Marsden, so that the other hospitals could focus on treating COVID patients and surgical emergencies. And all those patients were treated in a coronavirus-free site. In terms of chemotherapy, the UK BCG has also given a good guidance on patients who should be prioritized for treatment. Of course, patients with life-threatening disease that should be on top of the list. Those are patients with a first-line metastatic disease. Second group would be patients where the chemotherapy would give a benefit on overall survivors of more than 10% over 10 years, like large, not positive, triple negative, HER2 positive patients. And then those with much less benefits will go down on the list. In terms of radiotherapy, again, this is an area where here in the UK we had lots of advancement and the practice has changed a lot to incorporate new evidence during the pandemic. For example, patients older than 65 or younger, if with relevant comorbidities, could have no radiotherapy at all and just endocrine treatment if their cancer were up to 30 millimeters with clear margins and a low risk profile. Radiotherapy also, compared to the traditional schedule over 5 weeks, which is usually given in the UK or in Europe, they were given a 5-day course, so just 1 week on treatment, according to the results of the FAST trial, which reduced considerably the number of attendants to the hospital. Again, partial breast irradiation, quicker. The hypofractionation given for invasive disease can be used for DCIS as well, and boost radiotherapy can be omitted unless there are significant risk factors or the patient is very young. Nodal radiotherapy has been omitted sometimes in patients with T1 cancer, either positive, HER2 negative, low grade. So this is an example of a patient I had to deal with during the acute phase. So at 34 years old, when I have family history, which was on annual MRI screening, she had her MRI just before the screening stopped. And she also had genetic testing and was awaiting for the results. Her last MRI picked up a small cancer of 7 millimeters, which came back as a grade 2 triple negative breast cancer. Her gene test came back showing a mutation in the BRCA gene. So of course, she would have liked to have a bilateral mastectomy and reconstruction. She was already thinking about it, but now the reconstruction is not available. So what would you do what would you tell to this patient? And how can you counsel her? What's the plan? This is another thing you could discuss later on. So after the pandemic has hit, then it started the recovery phase. So you can imagine you are on top of this huge wave, and then this gradually levels down. The situation starts to calm. Number of admitted patients are reducing, and you can slowly start to reintroduce some service. So the breast screening will restart. That's where we are now in the UK. First with high-risk patient, and then the routine screening will restart. We're still continuing to triage all the referral, but now, of course, you have a lower threshold to bring a patient in compared to when we were in the acute phase. During this phase, you have to consider both the national situation in the eventuality of a second peak, but also local situation. If there are local outbreaks, what are the facilities available in your hospital? And all of this has to be included in the treatment planning for your patients. The aim in this phase, if possible, should be to see every patient with a lump or suspicious symptoms in the clinic. And this should include even elderly patients if they are otherwise fit and well. Telephone consultation should still be continue for elderly patient and patient with comorbidities, and for patient with low suspicion of cancer. As you may have more space in theater, you will be able to get through your waiting list of cancers. And if you've got space available, you can start to reintroduce some non-cancer work like duct excision, phylloides tumor, risk-reducing mastectomies for BRCA carriers, or symmetrization mastectomy for women who want symmetry and be flat on both sides. Of course, because breast reconstruction is still not available or may not be available in many centers, in this phase, you may start to consider neoadjuvant chemotherapy for downstaging again, because if you avoid the mastectomy, then you don't have to face the problem of delayed reconstruction. So you can also introduce oncoplastic procedures slowly, because they will allow to increase the rate of breast conservation. And finally, if you have the capacity and you feel confident, you can start to slowly reintroduce breast reconstruction in selected cases. Oncoplastic breast surgery itself, it's a time-demanding surgery compared to a simple lumpectomy or a mastectomy. What you have to consider is how much capacity you've got in theater. And you have to think that if screening has restarted, then you will have, again, all that burden of screening detected cancer to treat. So you may be prepared to have to stop doing it again in case you cannot cope with the demand for surgery. This should be only offered to selected patients with no risk factors like smoking or diabetes, because you want to keep your complications as low as possible. And symmetrization surgery, for example, if you're doing therapeutic mammoplasty, patients may want to have the other breasts reduced as well, but you should offer that as a delayed procedure to reduce the time in theater and the risk of complications. And of course, prefer the simpler option as much as any time as possible. Breast reconstruction. This is tricky. Breast reconstruction, they have a considerable rate of complications compared to simple mastectomy. You may have readmission, return to theater for infection. So you have to be really cautious, and before you start doing that, you need to be sure that you've got the capacity and appropriate facility even to deal with these potential emergency cases that it's time demanding again. So for example, bilateral cases should be performed with 2 surgeons operating, 1 on each side, because bilateral reconstruction is known to have almost twice the risk of complications, but that's mostly related to a long time in theater. So if you can cut that down by half, operating simultaneously on both sides, that you should do. And also, again, it should be offered only and only to low-risk patients. In terms of a nationwide situation, some units may be able to reintroduce oncoplastic and reconstructive procedures sooner than others. So it's very important that you network with your plastic surgeon colleagues and with other units. And it's very important to discuss with the patient all the potential options, even if that includes refer the patient to somewhere else to have the operation and losing the patient. So this is another example, a patient which I operated first time in February, 21 years old lady, very young and fit. She presented with a small lump in her left breast, which was biopsied and unfortunately was a cancer. I did wide local excision and sentinel node biopsy, and the histology was, as you see, 7 millimeter grade 2 ductal carcinoma, ER/PR positive or 2 negative, with 1 positive sentinel node. Treatment we offered her was adjuvant chemotherapy followed by breast radiotherapy. We gave her the option either to have node clearance or radiotherapy to the lymph node as well after chemotherapy. And we also tested her for BRCA. I saw her back in July last month. She completed her chemotherapy. She had, unfortunately, a BRCA2 gene mutation, and she was still waiting for her breast radiotherapy and axillary treatment. And of course, she wanted to discuss bilateral risk-reducing mastectomy and reconstruction and some treatment to the axilla, but in our unit, breast reconstruction is still not available. So what to do? Again, we can discuss this later. Finally, once all the water is flown, you're left with the aftermath, all the damage, and you have to start working hard to recover. So it's very important that tsunamis, like this pandemic, sometimes it's not just a wave, so there may be another wave coming. So you could pass from the recovery to be in the acute phase again. So it's very important that you're flexible and capable to adapt and go back to the situation where you were before. This is very important. In terms of the aftermath, for us as breast surgeons, there will be some changes to the way we used to operate, which are here to stay. For example, we have now introduced virtual meetings with Microsoft Teams. Also, our MDT now is virtual, with just a few people attending physically in the room. And those things are likely to stay. They will increase the attendance to those meetings as well. Also, previously we used to bring back all our patients after a biopsy result, even if the result was benign. now we started phoning them, just calling them over the phone, and that's actually useful for us because it reduces our workload, and also the patient don't have to wait for an hour, maybe in the waiting room, just to be told, oh, everything is fine. So this we have decided to keep. And also virtual consultation in selected cases. I think this will remain. For example, primary endocrine clinics. If the patient thinks that the lump is not growing or they are not concerned, you may just call them, and in case they have concern, you could arrange for them to come. And the same would be for cancer follow-up. I think probably what will be the biggest challenge, at least here in the UK and Europe and United States, will be to deal with the massive backlog with delayed breast reconstruction. We have stopped all this type of planned surgery, and all these patients, we are now just offering simple mastectomy. They will want to have a breast reconstruction. Symmetrization procedure we are not doing, that we used to do at the same time with therapeutic mammoplasty. All of this will need to be dealt with, and unfortunately, it's unlikely that you will have extra space to do that. So I suspect this will be a huge challenge in the next couple of years or so to get in track with that backlog. And pretty much that's it. The aftermath, we are still not there anywhere. Some places like, for example, South Africa, they're now being really hard. So they are in the acute phase. Here in Europe, we are almost getting to the aftermath, hopefully, although there may be a second wave, which is already hitting Spain, for example, United States, South America. They're still actually being hit really bad. So there is no one size fits all really, but hopefully this brings you up the viewpoint from the UK and some point of reflection that generally applies everywhere.
Thank you very much, Emmanuel. Very excellent presentation. And we're very privileged to have you on board as our resource person for today. There was a comment on the chat to ask if we would have access to your slides. And based on your gracious permission before this meeting, we've agreed to share your slides.
Absolutely.
Yeah, especially with the guidelines that you've given there, because unfortunately in settings like ours, there is no concrete guideline on how to approach these patients, which is one of the reasons why we've been having these webinars, to give people guidance and a platform to discuss. So this is very important. Thank you very much. So I know that you painted some teasers for us as those case and scenarios, and we'd like to know what you eventually did to those patients. Before we get to that, I have a number of questions for you, which I've harvested from some folks before this meeting. So the first question is, if you have a scenario of a patient who has a suspicious breast lesion on imaging, whether on MRI or ultrasound scan, and you've done needle biopsies and they are negative and it still looks suspicious, and you don't have access or you don't have space to do a biopsy, an open biopsy for these patients, or you don't want the patient to come to theater, is it possible to start the patient, if elderly, on primary endocrine therapy, presumptively?
That's potentially it is. But you need to think about what kind of patients you're talking about. If you've seen an elderly patient, or maybe a patient with severe comorbidity, postmenopausal, then you know that the majority of cancer are estrogen receptor positive, so that could be an option. But that has to be discussed. You need to have a frank discussion with the patient or with their GP, because and also it will depend on how big this cancer is. If you've got a very large cancer, well, that may not be operable anymore if you wait a few months and the primary endocrine doesn't work. So maybe it's better to do another biopsy in that case. If the lump is smaller, then yes, you can do that. Particularly if the patient is young anyway, as I said, you should place a clip inside the lesion because sometimes, particularly if you're on this endocrine treatment for a long time, the lesion could completely disappear, which we've seen once. For example, a patient I operated I think it was in June. She was started on letrozole in April, and there was no cancer left after 2 months. That was quite exceptional, but it's an eventuality, so you need to be prepared to that.
Yeah, interesting.
But
Thank
yes.
you very much. Yeah. So the next question is, what's your approach to screening patients who come to the hospital for breast cancer surgery? Do you screen all patients? And if you do, what do you use for screening?
So the screening we are doing here.
For COVID-19.
So the screening would be a mammogram, which is usually done every 3 years, starting from age 50.
Oh, sorry, my mother. I was talking about screening for COVID-19, for coronavirus.
Oh, I see. Sorry about that. So, a patient coming to the hospital for a consultation, we do not screen them, but we ask them to wear a face mask. And we also do wear PPE. So we've got gloves, apron, a visor, and a surgical mask as well. And I think that's generally enough because you won't be doing any high-risk procedure there, and the contact will be limited. All patients being admitted to the hospital, yes, they get tested 48 hours prior to the admission, and we also ask them to be very careful with their social interaction for the 2 weeks before the operation. And this is because you want to keep the operating site free for COVID.
Thank you very much. So I think I just have 2 more questions for you. So the next, or 3 more questions. The next question is about anesthesia. So we know that general anesthesia is the preferred modality of anesthesia for major breast surgeries. But anesthesia is an aerosol generating had an experience alternatives to general anesthesia, like regional anesthesia, breast blocks for patients, and they do breast blocks for mastectomy.
So I didn't get all of that answer, Ademola, but I think if I understand right, you're asking because of general anesthesia is aerosol generating procedure if I've got experience with blocks,
Yes.
regional block for mastectomy. So I do have, because that's something we've worked a lot while I was in Italy. Unfortunately, here in the UK, it's still, the anesthetists are still very reluctant to do that. So they will do a block, but just for post-operative pain control. But yes, that's definitely an option. But you have to think that the standard security COVID protocol that involves that the patient is intubated on the surgical bed. The anesthetist is wearing full PPE, including FFP3 mask, visor, a full gown, and protection. So you've got 2 options. Either you operate on full PPE as well, and then you're kind of safe, even if there is an intubation or some emergency maneuver there, or you just wait a few minutes after the patient is intubated before getting into theater, right? So you can manage that. And that the risk then, once the tube is in place, is minimal. If you're doing a block, which is fine, I like it actually, particularly for elderly patients. I've done mastectomy and clearance with that. But say the block is not working, okay, and the anesthetist has to intubate the patient, then it will have to do that on the rush with you there, so you may end up being more exposed to aerosols. So yeah, definitely it's an option, but you have to think, what if it doesn't work?
Interesting points there. So you talked about trying to do day case surgeries as much as possible. So for patients who have major breast surgeries and they have a drain placed in at the website, I assume that they go home with their drains in situ and they manage them at home.
Yes.
So
yes.
what's your thought for that?
So we tend to send home patients even after clearance, if possible, with the drain. Patients are instructed on how to change the bottle, and they usually have follow-up with the nurse in about a week time to check the wound, and the nurse will remove the drain, take the drain out at that time. So we provide them with a bag to carry the drain, and we tell them how to change the bottle if that fills up.
Nice. So the last question here is concerning contralateral breast surgeries. So is it your practice if a patient has bilateral breast cancer, do you operate with one surgical team or two surgical teams during this pandemic to shorten operation time?
So if the patient has a bilateral cancer, then if possible, we try to operate on both sides simultaneously anyway, if it's a mastectomy. But usually you can manage, even with just with one surgeon, you can do both sides fairly quick. If it's just a simple mastectomy. The time thing is more important if you're doing reconstruction, because then, of course, the time for a skin sparing mastectomy will be longer than a simple mastectomy. But yes, ideally, you should be able to operate on both sides simultaneously to reduce the time.
Thank you so much. So those are the questions I harvested. If there are other more questions, we may see them in the chat. But I think we can quickly go into the scenarios you painted. What did you actually do for those patients? Whether the acute phase patient and the recovery phase patient.
Okay, so let's see. Actually, the first one, it's so this one. The first one is interesting. So as I said, this lady, we had this plan agreed already. So the days just before the surgery that week, every day it was getting worse, more COVID patients. It was in the air, oh, surgery is going to be shut down. So I operated on her on the 25th of March. And actually the theater shut the week after. So I didn't know that because they were not telling us yet, but it was in the air. So at the end of the day, I said, if I just do the lumpectomy and leave a cavity there, there will be no chance to do the second stage of surgery, and you will be left. The patient would have been left with a huge deformity. So I had to see the patient, meet the patient in the morning, and be frank about that. I said, look, this is what's likely going to happen. So we've got 3 options here. Either we carry on as planned, but you know, I'm really concerned the second stage will not happen. Either we take a risk and do both stages together. I normally don't do that for DCIS with calcification because the chances of getting positive margins are higher. And it's easier to do audio excision when you've got the cavity open and not filled with a chest wall perforator flap. Or you can have a mastectomy without reconstruction, which the patient, of course, didn't want at that time, on that day. So at the end, we decided to take a risk and doing the surgery in one stage. Unfortunately, I took the area out and it was clear, but let's say to risk less, I did a superior margin shave, and the main specimen was clear, but in the superior margin re-excision I did, there was some non-calcified intermediate grade DCIS, unfortunately. So we had to recommend a mastectomy on the basis of that. And the patient is still waiting for it because she wants reconstruction. So yeah, in this case, it didn't pay off, maybe. There are any questions about this one? So this patient here, 34 years old, she was very keen on having breast reconstruction. She knew that she needed a bilateral mastectomy, but of course that surgery was not available at that time. We had this discussion at the beginning of April, where we were just restarting to operate. So what I discussed to her were these two options. So option one would have been having bilateral mastectomy without reconstruction. The other possibility, which is what the patient has decided at the end, was to do just lumpectomy and sentinel node biopsy with a perioral incision. Then the patient, she would have had chemotherapy, which is what the patient is having now. And hopefully once she has completed chemotherapy, we will be able again to offer breast reconstruction. So she will be able to have both breasts removed and reconstruction. Should that not be possible, then one option would be having radiotherapy, or we could refer her to a center where they're currently able to do reconstruction. So it's not what the patient wants here, but you have to counsel them, because of course delayed reconstruction will never be as aesthetically pleasant as an immediate reconstruction. And also you have to consider that it would involve at least 2 operations, particularly in a patient like this, which is very slim. So you will need to use an implant.
Interesting. So I guess you still have one more patient, the recovery phase patients?
Yes, this patient here, again, there are a bit of points to include. Of course, in normal circumstances, a patient like that, what I would have done would have been a bilateral risk-reducing mastectomy and an axillary node clearance, okay, with reconstruction. But there are a few things here which we had to discuss. So number one, the patient wanted reconstruction and she would prefer implants. So the first thing I had to discuss with her was, if you decide to have the mastectomies now with delayed reconstruction, then you could have the axillary node clearance and then implants later on with a 2-stage procedure. But that will involve you having an axillary node clearance. The patient is very active and fit, so she was concerned about developing lymphedema or limitation in the shoulder movement. The other option was to have radiotherapy to the breast and axilla, and then the mastectomy afterwards. With implants, that would put her a bit of an high risk of capsular contracture, which again, she was a bit worried about. So another option, which in this patient, you should really push for autologous reconstruction. So that's a win-win because the patient will get radiotherapy to the axilla, which has a lower rate of lymphedema compared to surgery. Lymphedema is about 15%, with radiotherapy is less than 10%. And also radiotherapy that will not affect the autologous reconstruction. But again, the patient is young. She doesn't have enough tummy to create 2 breasts. So I have referred her for a second opinion on a specialized center where they use tissue from the inner thigh to reconstruct the breast. And the patient for now has decided that it's more important to treat the cancer that she has properly instead of not having radiotherapy to the breast and wait. And she has decided to go on and have breast and axillary radiotherapy and then deal with the risk-reducing surgery later, which I think she did the best choice. So that's what I would have done. But yes, so this consultation are quite challenging because you have to be honest, open, and also try to be in the patient's shoes and also give them a picture and all the possibilities so that they have realistic expectation and they really understand each of these scenarios so they can make a decision that they don't regret in the future.
All right. Thank you very much, Emmanuel. It's been an interesting afternoon and we spent about an hour or so. I know we've gained a lot of things from your discussion and we hope that when we have a look at the slides, these things will be more internalized. I'd like to thank everybody once again for joining us in this interesting webinar. It's been a very interesting month for us, having to run webinars almost on a 2-weekly basis. And we'll share the links to the recordings once they're available, as well as the slides once they're available on digital platforms. Emmanuel, we cannot say thank you enough for all you've done for us and for free and out of your busy schedule and out of your time. We really appreciate you and hope to catch up with you later on. So on behalf of everyone in the team, especially my wife, Dr. Mrs. Yemisi Adeyeye, who has been in the background making sure that everything works out fine, I'd like to say thank you for joining this webinar and have a pleasant week ahead. Goodbye, everybody.